Hello, and thank you for joining me. My name is Jennifer Justice, and I'm a PMHNP student at Eastern Kentucky University. This presentation focuses on the integration of trauma-informed care, or TIC, for women who have experienced intimate partner violence, a public health crisis that affects 1 in 3 women globally. Intimate partner violence not only threatens physical safety, but has deep psychological consequences, including depression, post-traumatic stress disorder, and long-term trauma. According to the World Health Organization, IPV is one of the most common forms of violence against women, often leading to devastating emotional and functional impairments. Why trauma-informed care? Trauma-informed care provides a compassionate, evidence-based framework. It emphasizes safety, trustworthiness, empowerment, and cultural sensitivity. These principles are essential for restoring agency in women who have survived violence and trauma. As noted by SAMHSA, TIC is a best practice approach for addressing trauma's complex effects on health and behavior. This project is grounded in the Title Model Theoretical Framework by Barker and Buchanan-Barker. The Title Model is a person-centered, recovery-oriented framework that centers the individual's narrative as a foundation for healing. This aligns closely with TSC as they both emphasize empowerment through shared decision-making, respect for lived experience, and rebuilding a sense of control and safety. The effectiveness of trauma-informed care interventions for women with IPV has been well documented. A systematic review by Chu et al. In 2023 found significant reductions in depression, PTSD, and psychological distress. In Pakistan, a culturally adapted, trauma-focused CBT program reduced PTSD and depressive symptoms among IPV survivors, and this was found also by Latif et al. In 2023. A UK-based community TSC program improved emotional well-being, self-worth, and trust in providers. This was provided by Warwick and Booth in 2022. This intervention will be delivered by an interprofessional team, including psychiatric mental health nurse practitioners, primary care providers, social workers, and behavioral health specialists. Key strategies include screening for IPV, depression, and trauma symptoms, creating safe and supportive environments, providing culturally tailored, trauma-focused mental health support, and promoting shared decision-making. To evaluate this intervention's effectiveness, we will use the Hamilton Depression Rating Scale, also known as HAM-D, a validated tool for measuring the severity of depressive symptoms. By assessing the symptoms before and after the intervention, we can track improvements and refine care delivery. The implementation of this process includes identifying participants through partnerships with shelters, primary care clinics, and community agencies, baseline assessments including tools such as the HAM-D and DSM-5 trauma scales, delivering the intervention over 12 weeks, using trauma-focused CBT and culturally responsive care, post-intervention assessments and team debriefings, analyzing outcomes to inform sustainability and integration into routine practice. This timeline reflects a structured, intentional approach. Collaboration with community and clinical partners begins in January. Screening and participant recruitment takes place over the first 2 months. In March, participants are formally enrolled, following information sessions and consent processes. From March through May, the core intervention is delivered across 9 trauma-informed sessions, guided by CBT principles and cultural adaptations. During this time, weekly team meetings help monitor participant progress, address logistical barriers, and maintain fidelity. Immediate post-intervention effects are evaluated in late spring, with longer-term outcomes measured through the end of the year. In December, all findings will be analyzed and shared with key stakeholders, with recommendations for sustaining the program in clinical practice. If outcomes are favorable, this trauma-informed approach will be embedded into ongoing practice. Training, supervision, and institutional support will be key to long-term sustainability. In summary, integrating trauma-informed care rooted in the title model, supported by evidence-based measures like the HAM-D, and delivered by a collaborative team offers a compassionate, effective path forward for women survivors of IPV. Thank you for watching.